Some doctors treat what's broken, others prevent it from breaking in the first place. Dr. Pedro Martinez-Clark is redefining how we think about heart and vascular health by bringing world-class care out of the hospital and into the community. The doctor who keeps blood flowing. Next on DocStars.
Welcome to DocPod's DocStars.
Hello, everyone. I'm JJ, and welcome to DocStars on the DocPod channel. Today's guest is Dr. Pedro Martinez-Clark, a Harvard-trained interventional cardiologist and founder of Amavita Heart and Vascular Health here in Miami. Now, at its core, Dr. Martinez-Clark is a heart and blood vessel fixer. We're going to go over this today. It's quite interesting. When blood stops flowing where it should, whether that's to your heart, your brain, or other areas of your body, he's the doctor who steps in to open those pathways and get things moving again. He's using tiny catheters instead of scalpels to save lives and limbs every day. So from free mobile screenings to bilingual staff and neighborhood partnerships, Dr. Martinez-Clark's mission is simple. Nobody should lose a leg or ultimately a life because they couldn't get the right care or access. So Dr. Pedro Martinez-Clark, welcome to DocStars.
Wow, JJ, what an introduction. It's fantastic to be here.
Wonderful. You and I were talking off air a little bit. You know, I did a bit of a deep dive on you the last couple of days and hearing about your journey. And even you and I talked about Colombia prior. And I think it's very interesting when I see someone like yourself who's come from, Colombia, made their way all over, and you end up in this incredible journey in medicine. And you started your medical journey in Colombia before training at Harvard's Beth Israel, I believe it's Deaconess Medical Center, which is really impressive. And I'd love to know, from you, how all these experiences early in your life and starting in Colombia, moving around, I'm sure the US, how these shape the way you see medicine today before we go a little bit deeper into some of the specifics of what you're doing.
Yeah, no, that's a great question. I mean, it's been an interesting and fascinating journey. And I have to say that I grew up in a family of, my father was a physician, so I grew up in that environment. A couple of my uncles, and so I was born and I grew up in that environment. And we also had a lot of family in the U.S. and we were very close to that extended family. So I grew up spending all my summer camps and a lot of my vacations and here in the United States, and also did a couple of years of high school here. So I was very fortunate to grow up almost very bicultural, and was able to. And I was also lucky to meet really cool friends in the U.S. and had amazing friends here and amazing friends there. So I was always very bicultural. And obviously at the time in Colombia, it was considered very prestigious to kind of do medical school and then get a postgraduate degree in the U.S. and then go back to Colombia, and then you'll be like, oh my God, this the star. And that was kind of the intention at the time, and go back and continue kind of like dad's legacy. But unfortunately, obviously, as most people know, Colombia has had some political cycles over the years. And when I first started doing rotations and experiences here in the U.S., one of those political cycles sort of hit Colombia, and it wasn't a very safe place to be. And it was logical to think about maybe I'll pursue a little longer of training here. But longer training leads to more friends and more relationships and deeper roots here. And then one thing leads to the next. And I started doing research in one of our projects got significant amount of attention, so that opened a lot of doors, and it's sort of wow, a lot of opportunities. And eventually you invest so many years of training in the U.S. that you start to disconnect yourself from the daily life in Colombia. It's harder to go back than, you know what I mean? From a cultural perspective, you become more American than Colombian, so So that's the
Yeah.
practicality of it.
Yeah, 100%. It's very interesting too, because when you were younger, did you think, in your wildest dreams, and maybe you did, like, hey, I'm going to be at Harvard one day, one of the most elite institutions in the world, and I'm going to really do incredible things like this? I'm sure we all have dreams, but I'm curious what you were thinking when you were younger. Was that your goal?
No, that never really crossed my mind, honestly. But I was in Colombia, and I had this really good mentor, because I really believe in mentorship, and I've been blessed with very good mentors, and I try to be a very good mentor for younger physicians, etc. But my very first mentor was this guy, Dr. Villanueva in Colombia. This guy was a really smart infectious disease doctor, and he had done infectious disease training at the Brigham and Women's Hospital at Harvard University.
Mm,
And I started doing research with him, and there was an epidemic of a very weird bacteria that happened uh, in a very specific region in Colombia, which is called the Sierra Nevada by Santa Marta. Maybe you heard of it.
hmm
Um, so the native Indians developed this very weird bacteria, and Dr. Villanueva was called to go look at this situation. And he noticed that, to his knowledge, that had not been reported. And he, obviously, because of his training in Boston, he had really good relationships in the infectious disease space. And he got the CDC involved, and this became a very big deal. This was like the first time that this bacteria had been reported. So that led to publications and things like that. And he's the one who basically told me, look, you know, um, you should go to Boston and do some research, and kind of built on this experience. And that's what I did. And then once I was there, you same thing. You start to meet more people. You get into a network. Your research grows. Your research expands. You meet other mentors, new doors. Obviously, there is extreme, significant amount of hard work and dedication and everything that goes into it. But obviously, you have to also be in the right place, in the right environment, to be able to get inspired and to understand that that's not only possible, but really tangible.
Yeah, it's an amazing story. Eventually, though, you make it back to Florida, right? And when you came back to Florida, is there something you saw that was missing, how cardiology was being practiced? And I'm curious how that kind of helped you realize and lead to Amavita.
Yeah. So when I was in Boston, I was extremely happy. Um, um, I'm super grateful for the opportunity to train at the Beth Israel Deaconess, and that was an incredible experience. Um, but once I finished my training, I wanted to be closer to my mom, my brothers, family, and for many, many years, because my brothers, they also grew up and they went to study to different places. It have been probably about a decade that we had not been in the same city altogether. And it so happened that they were all in Miami for circumstances, and I wanted to be close to them. And obviously, I'm a Hispanic person. I like Miami. Culturally, I feel more comfortable in Miami than in Boston. I love Boston. I love the Red Sox. I love everything about it. But the cold weather, you know what I mean? That's I'm not genetically designed to tolerate those. You know what I mean? So after that training, I was like, wow, I really feel like I want to be in warm weather. But it so happened as well that the University of Miami was rebuilding their cardiovascular program. And when they decided to rebuild this cardiovascular program, they brought this guy whose name is Dr. William O'Neill, another mentor. And Dr. Neal is this world-class cardiologist, and he was going to lead the entire expansion of the cardiovascular program. And my professor in Boston gave him a call and basically said, "Hey, I have this guy Pedro here. He belongs in Miami. He'll be great. For you. I think I think it'll be a good match." And that's how I got into academics and became teaching clinical trials, all of that here in Miami. And yes, medicine in
Well,
Miami has evolved dramatically 15 years later, in the sense that, to be quite honest, when you compare back in the day, when you compare the level of care and the just the quality of academics and everything in Boston compared to Miami, there was a significant difference. Well, I think Miami, South Florida in general has evolved dramatically, and that difference has narrowed down significantly. There is very specific things, that they might have in Boston or in Houston or whatever that we don't have here, but very specific niche things, and there are very specific things that we have here that they don't have there. So we, as a medical community in Miami, we have really evolved, and a lot of talent and very good programs are now available in South Florida.
yeah, which is amazing. And by the way, I do sympathize with the weather because I'm actually from Chicago, but my
Ah,
wife is from Brazil. And so
perfect.
that's why we're in Miami.
Exactly, exactly, exactly. And
We understand who runs things.
yeah, exactly.
But
Surely.
it's interesting. When I was doing, again, the research on you and I was looking at interventional cardiology, I read that it's kind of like a plumber for the arteries. So for someone like myself or the lay person, if you will, what does that really mean in everyday terms? Just a quick overview of what that means.
Absolutely. I tell patients the cardiovascular system is like a car or like a house. So let's use the example of a car. You have a pump and you have tubes that go in and out of the pump. And that pump is the engine. And then you have all these tubes that take gas or whatever they take from that pump somewhere and has to come back to that pump. It's as simple as that. It's really, really when you think about it, is really what the cardiovascular system does. And to be able to operate that pump, you need integrity in the pump itself and in the tubes that take things out of the pump and bring things back to the pump. And to be able to get that to move, you need energy. And that energy is the electrical system of the heart. It's as simple as that. So you can have
Hmm.
problems in the pump, you can have problems in any of the tubes, or you can have problems in the electrical activation of that pump, or you can have problems in all of them. And that's a real problem.
Yeah, it's incredible when you kind of distill it down, and that's something that we want to focus on, because I think there's a lot of times where we want more people and more listeners to understand what's going on in the medical field, but sometimes the terms and the talk is just way above most of our heads. So it's great when you distill it down like that, which makes it so much easier to understand, right?
Yeah, no, absolutely. That's exactly what it is. And what we do in interventional cardiology and endovascular therapies and all these names that we have for the sort of a variation of the same concept and a specialty is we are plumbers. We fix the pump, we clean the tubes, we replace the tubes, we do whatever we need to do to either fix the plumbing or to fix the electricity. And that's the analogy. So there are cardiovascular medicine is an incredible field because it is very diverse. It's very, very broad, and obviously is the number one cause of death in globally. So there's a lot of uh, investment attention. It's a huge market. So the specialty is very, 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 very big. So we have tremendous imaging. We have a incredible level of detail in technology to be able to diagnose and image things to a really high and accurate resolution and with very very high precision. And we also have very advanced tools, devices, techniques, technologies to fix whatever is wrong with the cardiovascular system.
Yeah, it's really, really interesting. And I also want to talk a little bit about kind of this fight against preventable amputations, because I find this really, really interesting. And I know Florida Trend Magazine called you the limb saver. And I think that's a very apropos name. But you launched the Miami Initiative to Stop Amputations, MISA, MISA, right?
Yes,
And I think
exactly.
that this amazing, amazing project. And I'm curious though, let's talk a little bit about that. Maybe just explain what that is. And then I have a few more questions about that because I love this project.
Yeah, no, absolutely. And it's gotten a lot of attention, and I think it's important to understand that that the number of amputations in United States, the non-traumatic amputations, meaning diabetes, arteries are blocked, um, is on the rise, and it's been on the rise over the last decade or so. And that's a problem when you think about a developed country like United States. There's no reason why people you know, shouldn't get access to this incredible minimal invasive technology that we have. So obviously in South Florida, um, uh, there is a tremendous opportunity to look at different demographics and different ethnic groups and look at certain patterns um, um, that are different in those groups. And one of those is peripheral arterial disease, which is blockages in the arteries of the legs, or it can be in the neck or whatever. But so for the listeners, when you have an artery that has a blockage or a cholesterol buildup, if it happens in the heart, it's called coronary artery disease. If it happens in the legs, it's called peripheral arterial disease. So peripheral arterial disease, when you look at the epidemiology or the demographics, it affects a lot of minorities, Blacks, Hispanics, low socioeconomic status. Coronary artery disease, affects everybody. But there is a significant concentration of peripheral arterial disease in this minority population or lower socioeconomic status sort of population. So in those patients are the ones that have less access or more barriers to access to care for education, for exposure, the disease itself, transportation, many, many factors. But one of the factors is the fact that 50% of the primary care doctors, meaning the doctors that care for those minority patients, don't know that their patients have peripheral arterial disease. So that's a crazy number. So
Wow.
when we started our practice, Amavita, we thought, look, um, we want to develop a concept of cardiovascular care that offers hope, that is happy, that is positive, good energy. I want people to feel happy when they come to our practice. The practice has to have a research component that's important for our, intellectual growth, etc. And number three, has to have a very strong community outreach. And the best mechanism to do that was to the creation of our non-for-profit, which is a separate arm of the practice, from a business structure. All of that obviously is a non-for-profit corporation, so it has a board, it has management, all of that. And then we design specific campaigns, and because one of those a huge interest was the fact that PAD affects all this minority population. And we have so many Haitians, Hispanics, African Americans here in South Florida. It was a really good opportunity to make an impact. So that's why we went after peripheral arterial disease. And we developed this campaign that is called MISA, Miami Initiative to Stop Amputation, which is aligned with the goals of the American Heart Association, and is a nice name because MISA means going to church for Hispanics. So it has a catchy name, so people like it. So that's why, because of the mission is very important, and what we're trying to do is very important, but also the name is very catchy because of the Hispanic culture and what it means for Hispanics, which is going to church.
Yeah. It's crazy how that number was so high, as you said. And I'm thinking about peripheral artery disease, as you said, PAD. It often goes undiagnosed, right? Until it's too late. Well,
Correct.
why do you think that is? I mean, if I go to my primary care provider, right? We all have them, and I go there and I check in, twice a year, like we do. Is it a lack of training? Is it something that they're just not on the latest and greatest on in terms of knowledge? But why do you think that is happening?
Yeah, it's multifactorial. One of the things that happen is when you think about primary care, and I mean, it's a very challenging specialty because they have to address so many issues in one given patient. So think about a 70-year-old uh, African American or Hispanic or it can be white. It doesn't it doesn't
Yeah.
matter. But low socioeconomic status that has diabetes, smoking, hypertension, hypercholesterolemia, that has a housing issue, that has some mental health issues, has so many issues that you as a primary care doctor, you have to kind of focus your attention in so many things that you kind of have to create priorities. And maybe
Yep.
he's not taking his medications correctly. He doesn't have good social support. He doesn't have a good system, non-compliance with his medications. Maybe he cannot afford so many things that they have to deal with. So that's one factor. And the other factor is the fact that PAD, one thing is a description of the disease when you read about it, but only about 30% of patients will describe the disease that way. Most
Mm.
patients describe the disease in a way that is unusual. My legs are fatigued, my legs feel kind of heavy, and I just get tired when I walk. So symptoms that are sort of non-specific. Your legs can feel, if you think about grandma or grandpa, their legs might feel tired for many reasons because they don't exercise regularly. They're older, they have osteoarthritis, they have chronic pain syndrome, 20 different reasons. So when you're a primary care doctor and you have a patient that has so many things and so many socioeconomic issues and describe, some vague fatigue in the lower extremities when they walk a little bit, that doesn't, doesn't make it to the top priority. When you tell a primary care doctor, I clean the house and I get chest pain, you get his attention right away. Yeah, so so it's a multifactorial issue.
Yeah, and again, I mean, this can happen, like you say. I think the primary care provider is so difficult. I lived in 4 different areas in 4 different years, so I had 4 different primary care providers, and so I understand what that process looks like. And it
Hmm.
is such a challenging job for them, right? Because they don't
Hmm.
have one specific thing to focus on, and so some
Yeah,
of these symptoms that I might say, oh, my legs are feeling tired. It's easy to misdiagnose that and just say, oh, it could be X, Y, and Z. And as you said, there's
absolutely.
so many other areas that they have
Yeah,
to prioritize.
yeah,
It's so
exactly.
difficult. So what I'd love to know that because you've set a goal, I think, from what I've understood, of reducing these amputations by a pretty good percent. I think I read 10 to 20% over the next decade, right?
Yes, that's what the what's kind of what the community wants. The
Mm.
community meaning the physicians and the healthcare community that is involved in this space. And what we want to do is get to patients earlier. We want to create screenings. We have to be able to interact with physicians, create awareness. do campaigns, etc. So we are out there we go to churches, community events. We partner with local foundations. We're constantly finding a way to make sure that we do screenings early, and those patients that undergo that free screening are directed to the appropriate channel. And we have a number of partners that are willing to take those patients and care for them, etc. Or simply it's a matter of notifying their primary care doctor. Hey, by the way, um, you know, I know he has significant issues, but we identify this, keep it on the radar, and we make sure that that patient is directed appropriately and early, so we can change the course of the disease.
Yeah, early detection, early intervention, getting the word out right, driving the narrative, as you said. So, if someone's listening today and they just heard of PAD for the first time, are there certain warning signs that they, or their loved ones should be watching for that might
Yes.
help their primary care provider kind of access and say, hey, that's what this is?
Yes, I will say if you, the listener, or your family member, if it's over 55 and has diabetes, history of smoking, he or she should have a very simple test to screen for peripheral arterial disease, or PAD. The test is extremely simple. It's a blood pressure cuff that we place in the ankle and a blood pressure cuff that we place in the arm, and we create this ratio because the blood pressure should be roughly the same in a normal human being between the arm and the ankle. And if you develop arterial disease, then you have a difference between the blood pressure in the arm and the blood pressure in the ankle. And when that difference in the very, very well-established criteria that we use, and if you have that test or your family member has that test, which is really, really cheap, it takes just a couple of minutes to do. That's a really, really good a screening test for peripheral arterial disease. So if you have diabetes or smoking or both, you should have a screening test for peripheral arterial disease. If you are an adult with similar risk factors, meaning diabetes, history of smoking, etc., and you have any kind of discomfort in the lower extremities, especially with physical activity, you probably have PAD. You probably have PAD, and you should really, and you must really have that screening test, and then more advanced testing like fancy ultrasounds, which are really really simple to do, but the resolution is amazing, etc. And if you have changes in your skin tone, or if you lose hair in the lower extremities, that's a very important sign. Those are very important signs that you probably have peripheral arterial disease.
Okay. So if someone's listening and now they know that and they have a primary care provider, they can actually go to them and say, "Hey, can I get tested or checked for peripheral artery disease?" And
Exactly.
if they don't, this is an interesting question. If they don't, what types of clinics would offer that? Can they just go to any clinic? I'm curious what that looks like.
Yeah, sure. I'll be shocked if the primary care provider wouldn't do that, because it is important. It's just it doesn't make it to that priority that we're talking about. Uh, but if that is the case, you can simply Google PAD Miami, and there is a
Mm,
whole list of us that are you know involved in the field or in the space of peripheral arterial disease.
okay.
Once you look for it and know about it, the issue is not access to one of us.
Yeah, exactly. That makes total sense. So, what do you think are the biggest advantages, let's say, of treating patients outside the traditional hospital system? Thinking about outcomes or experiences.
Well, that's a really really important question, because cardiovascular medicine and procedures traditionally have been procedures that have been associated with high risk. But our technology, our expertise, our tools, our skills, everything has gotten so much better. Our procedures now are so safe, and the the success rate and the efficacy of our procedures, for the most part, outpatient versus inpatient. Of course, there are a number of procedures that must be done in the hospital because they're really complicated procedures, complex procedures, multidisciplinary, etc. But the average procedure in cardiovascular medicine now has migrated to the outpatient space. And COVID really kind of accelerated that migration because a lot of people didn't want to go to the hospital and a lot of people don't want to go to the hospital. So, obviously, if I tell you that you need a procedure that we're going to do in the hospital, that causes some level of anxiety and stress. But if I tell you, hey, we're going to do a procedure that is minimally
Mhm.
invasive, that is done through a little catheter, 2 millimeters, is local anesthesia, a little sedation, is in an outpatient center that is specifically designed for this, meets all the standards in the world, and you're going to be home by 11 a.m. and you can resume your activities right away or the next day, you'll be like, okay, yeah, absolutely. So the outcomes for the average procedures are similar. The most important difference is cost. The
Mm.
same procedure in the hospital will cost you 3x what it costs you in an outpatient center. I'm making that up. 3x, it might be
Yeah.
2x. Obviously, we have to look at the specific procedure, but in average, it's far more expensive to get the same procedure in a hospital and to get it in one outpatient center. And obviously, if you add patient satisfaction and preference, if you add cost, and if you add the third element, which is physician comfort and preference, then all three ingredients favor outpatient centers. Because as a physician, your quality of time is so much better because in an outpatient center, like, let's say that I have 4 cases in the day that I'm at the outpatient center. It's only, all our attention, the entire staff, everything in the outpatient center is on those 4 patients.
Mm.
That's it. I mean, I mean, you feel, you feel like, oh my God. I mean, it's like incredible attention. In the hospital, obviously, excellent care, etc. But the hospital, just the intrinsic nature of a hospital, people are busy. There's a lot of stuff going on. You're waiting for your procedure that might be low risk, and then some guy with a heart attack, you know,
Yeah.
you see 911 running. I mean, you see, so that generates significant anxiety. Whereas, patient comfort, satisfaction, all of that in an outpatient center is much higher, and physician
Yeah.
time and efficiency.
Yeah, it's amazing when you think about cost, when I think about the patient experience, like you
Yeah,
said, when I think about
absolutely.
highly personalized, as you
Yeah,
said, right? Or
absolutely.
even, I feel like even yourself, the doctors even have a greater
A
hyper
hundred,
focus, if you
a
will,
100%.
right?
You have nothing. You have no distractions. You have four
Wow.
patients the entire day, and it's all about. So you have, let's say, the first patient you do, you start at 7:30 in the morning. The next patient you start at 9:30 in the morning. So you know what I mean. So
Yep.
you get all the attention all the time from everybody that is at the center.
Yeah. And I think you also made a good point that I think a lot of us normal patients, when we think, oh, I have to go to the hospital, our level of stress goes up, right?
Yeah,
And you think,
yes.
oh, wait a second, this must be really serious. Or I'm going to an outpatient, a clinic. So, you're known for performing minimally invasive. You mentioned kind of 2 millimeter catheters and stuff and
Mhm.
helping people avoid heart surgeries and limb loss. But can you
Exactly.
kind of walk us through like what one of those procedures looks like in plain language, just so we get a better idea?
Absolutely. So basically, we use different arteries to get to different places. So we want to get to Pembroke Pines. You have Broward. You might want to take Turnpike or I-95, depending on things, right? Depending on traffic patterns, etc. same thing we do. We need to do a procedure. We need to unblock an artery in a specific anatomic location. We choose an artery that is the straightest direction to that location. So we gave you a little bit of numbing medication. We place an IV in the artery, and we leave a small catheter. That catheter is about 2 millimeters in diameter, and you feel nothing.
Mm.
The only thing that you feel is really the numbing medication. After that, you shouldn't feel anything, because once the catheter is in place, inside is no feeling at all, and you get sedation. So you're really sleepy, kind of arousable, but you are sleeping. And um and then and then we place a X-ray contrast material inside the artery, and we take X-ray movies of the circulation. And with those X-ray movies, we know exactly where blockages are in the arteries. And we have this really cool lens that we can place inside the arteries, and we can see inside the artery specific areas of interest with a extremely high level of resolution. So we know exactly the diameter, the size, the composition, everything about that artery. And then we have a bunch of different technologies or tools that we can use to clean the arteries, or to
Mm.
place a stent or whatever. So, we might use a balloon to inflate the artery and separate the plaque. We might use a little cutter that we have to shave off the plaque and remove it from the body. We might use a little laser to go through that blockage. So there are a lot of tools that we can use depending on the amount of calcium in the blockage, the tortuosity, how many curves it has, the size, the patient itself, the size of the device. Sometimes if you're gonna if you're gonna unblock an artery in a small little lady, it's not the same to unblock an artery
Mm.
on a 6 foot, man. So, if the artery is bigger, you have a lot more many more options to choose from. So there are a lot of factors that go into that, but in general, these are very minimal invasive procedures. They're very safe, and we can treat a number of abnormalities in the arteries and veins, as well as in the heart, using the same principle.
Yeah, exactly. And so would they go in through areas like the wrist, or what areas would you actually go in with that
Yeah,
small
so
catheter?
so th- exactly. So it depends exactly on where we want to go. So let's say
Mm.
that we want to go to the heart. So if we want to go to the heart, we can preferentially, we use the wrist, because the wrist offers the ability of a fast recovery for the patient. You can
Mm.
have, might sound crazy, but you can have a cardiac catheterization, um, literally a little bit of sedation, numbing medication in the wrist. We place a catheter, it goes to the heart. We take pictures. And if, let's say that you don't have a blockage, then you're done in 15 minutes, and you can literally walk out of the table. Obviously, you're a little sedated, so you're a little bit, unstable. But
Yeah.
in principle, it's only the arm. We put a little wristband, and you can walk. And your recovery, which is, about an hour and a half, is just wearing off of the sedation, and you're sitting down in a recliner, watching a little movie and stuff like that. So our
Wow.
procedures have become so safe, because our techniques have evolved so much, in our just the technology that we have available
Yeah.
is just incredible. So it's really sad when we see patients that don't have access to that. Not that it's fair anywhere in the world, but it is especially unfair when it happens in the United States. You know what I mean? Because here you have,
Yep.
the most incredible technology.
Yeah. Especially when we can do it, it's there. And because of disadvantaged areas where people live, or because of
Exactly.
their income
Exactly.
level, they don't have access to this, right? And you
Exactly.
mentioned you mentioned technology, and I love technology. I'm a bit of a tech nerd on the side, and I'm curious how that's changing the landscape of interventional cardiology, because I would imagine all of these catheters are getting smaller, so the cameras are getting better, all of this stuff. Where do you see it heading in the next few years? I assume it's helping tremendously, yeah?
Yeah, absolutely. In fact, I'm very involved in the use of artificial intelligence in cardiovascular medicine. And there are many areas where it's impacting the care or the business of cardiovascular medicine. And I say the business because there are many factors that go into a doctor delivering care. You have insurance verification, you have authorization, you have denials, you have so many different steps in the process. You also have to check on the patient medication reconciliation, compliance, the follow-up, the procedure, the consent forms, the so many different aspects to an encounter. In artificial intelligence, has already made a significant impact in the efficiency of the workflows that we use in cardiovascular medicine. So that's one aspect where it has already made an impact. Number two is the way that we interact with patients, because I don't know if it's been your experience, but one of the biggest reasons why providers burn out is because of the excessive documentation.
Mm.
So I'm seeing you for 10 minutes and I'm typing because there is no connection. So AI has allowed us to just have a conversation, and the system can pick up the conversation and translate that into a medical compliant note that you just simply edit or whatever. But it allows for those 10 minutes to be more quality, so the patient satisfaction goes up, the relationship is better, etc.
Yeah.
And then on
Makes
the
total
actual,
sense.
and on the diagnostic side of things, AI has is already changing our ability in a good way of diagnosing things with a lot more accuracy, because obviously machine learning, etc., are just better than humans. So
Yeah.
our diagnostic ability when we use AI processes into those diagnoses is so much is incredible. So you have less unnecessary procedures, better algorithms. You're able to detect so many more arrhythmias, so many, so the diagnostic side has been impacted tremendously.
Yeah, it makes so much sense. And as you said, I mean, if you think about that low hanging fruit, right? For doctors, it's about being as efficient as possible so you can spend as much time focusing on the patients. And if
Yeah,
AI can help us with that, it's an
absolutely,
amazing thing, you know?
absolutely.
Yeah, we were talking about, again, I hear in Miami areas where people are disadvantaged. So let's talk about that community outreach, right, and equitable care, because it's really what I read a lot about, where medicine has a chance that meets people where they are. And you've
Hmm.
been outspoken, I think, about health inequity, about how
Hmm.
transportation,
Yeah,
language, as we talked
yeah,
about, right, having
hmm,
translators, and
yeah.
trust often matter as much as technology, if not more.
Mm.
So what are some of the most common barriers, right, in some of these underserved communities? We talk about language, we talk about maybe financial situations, but maybe walk us through some of those that you really experience a lot with.
Yeah, so I would say transportation is a huge
Mm,
one. A lot of
yep.
one of our offices is in North Miami Beach, where and with a very mixed, diverse population, and the number one uh, reason for missing appointments and things like that is almost always transportation. Is because they don't, they cannot get to the office because they don't have a family member or a strong social support, or they don't have, or they have a son or a daughter but has to work. And
Mm,
and you can say, okay, but I can take a couple of hours off to take my mother to the cardiologist, but not everybody has that luxury. So a lot of people have to work, and especially when you have to see that patient every month because he has a serious cardiovascular condition. You have to keep an eye on the patient, etc. So I would say in our case, transportation is a big issue. Number
yeah.
two, which is important, is direct financial. They are
Mm.
a significant number of people that just simply don't have $20 for the copay. It's as simple
Yep.
as that. And you have to figure out ways of eliminating those barriers, because it is important to provide, the care that a given patient needs. But in but it's a complicated problem, obviously, and we do what we can to help and to fix things, but it's a macro issue.
Yeah. Yeah, exactly. And again, we know that, speaking of transportation, like you say, in finance, obviously in Miami, there's a lot of people who speak Spanish and maybe some Creole or French or different languages. But I think having a bilingual staff, which you guys do, and obviously community partnerships, that helps
Hmm.
tremendously because I think certain people just feel insecure if they can't speak to you properly, right? So
Absolutely.
that's a great one
That's
as well.
that's a great point. Especially because the Haitian population in South Florida is significant. The North Miami
Yep.
area has significant number of Haitians, which I love the Haitian patients. They're great. I'm so grateful. But obviously it's a foreign environment to them. It's unusual to them. And if there is, and we have a person in the staff. Her name is Pascal, who's an incredible ambassador for the Haitian community, and she's our liaison for with them. And she's so important to us because you know people come to the practice and they ask for Pascal. They don't ask for me, which is great. I love it. I think that's
Hmm.
fantastic. And you have to have those team members. You have to make sure that people feel comfortable in the practice, regardless, that is culturally sensitive to all the different groups.
Yeah, it's so important, so important. And again, I mean, you offer mobile peripheral artery disease pad screenings, which is
Hmm.
pretty incredible from what I read. Free
Yeah.
rides, right? Or rides to get patients there, which is
Hmm.
almost unheard of, let's be honest. So, I always love to know the why behind people like yourself who are doing amazing things. Why is access such a key part of your medical mission? I know we've kind of touched on it, but it must go deeper than just saying, I know I can save more limbs and all of these things. There's something inside you that's driving you to do this, right? Which is incredible.
Well, is honestly is the sense of gratitude in the philosophical obligation that I have to give back to a community and to be a mentor to young medical students and to young individuals that are thinking about science. And because if you think about it, I'm some guy from Colombia that ended up in Harvard. I'm a lucky guy. I have to, I feel a moral obligation to give back. And one of those, individuals can be my mom or my family
Hmm.
member. I want to do, whatever I can to make sure if I help one person, I feel, I can't fix everything, but at least I helped somebody. I did something good. So if, I, transportation is such a huge issue, and going to where the patients are going, um, to the communities. They feel more comfortable in their church. Okay, let's do a screening in the church. It's as simple as that.
Yep.
We have our machines are smaller now. Let's make it a fun day. Whatever. Let's be
Hmm.
creative. Let's think outside the box, and let's accomplish what our mission. And that community outreach is a such an important part of our practice overall. So it's the clinical research. I think you have to deliver clinical care, you have to do clinical research to advance the
Hmm.
field, and you have to have some sort of community outreach that brings you closer to the community. That's you. At the end of the day, you're a physician, right? You have to, and in my personal case, I'm very grateful, and I feel obligated
Yeah.
to be close to the community.
Yeah. Which is incredible. I mean, because there are plenty of doctors out there, but not everyone is doing this. And so, when I look at this and I think it's an incredible project, and I'm thinking, why don't we just get with the mayor, get with the top politicians and say, listen, why don't we have a PAD peripheral artery disease day screening, and we throw some money at it from the city, and then we can go to these areas, get on a bunch of mobile procedural buses or however you guys do this, and
Hmm.
get all these screenings done. Because when you look at how many limbs it can save and maybe even ultimately lives, it should be a priority, I would think. But yeah,
Absolutely. No, and I think we will, honestly. And
yeah.
I think that that obviously we've been growing our non-for-profit in a granular way, but I think 2026 is going to be the year where we're really going to shift a meaningful amount of resources to the foundation to scale the foundation. And like anything, you need the right team, the right infrastructure, the right strategy to be able to take it from one screen a week to really a big operation. And to be able to go look for those grants and supports and partnerships and all that, which we have a lot of those, but it can be we're going to scale it in 2026 because as an organization, we have reached certain milestones that allow us to shift some of those resources into that effort.
Mm, incredible. So I'm wondering, how do you actually measure, let's say, success when you're doing something like this? Because I think, is it the number of procedures you perform or the number of amputations you prevent, the number of screenings? What does that look like for you? Because it seems like there's different areas to focus on, right?
Absolutely. There's different metrics that you could
Mhm.
come up with. For us, is the number of screenings and the number of patients that we are able to sign up to our screening. Because if you think about it, our project is relatively new. So I
Mm,
think the first phase of our project is let's screen a lot of people and let's make sure that we identify the ones that are abnormal and get them to the right place. We trust that organization that once it's in that place is going to be okay. That health system is going to take care of that patient. The problem is that the patient has PAD and is out there and nobody's taking care of them. The problem is that
exactly.
the feet are changing colors and nobody notices. That's the problem. So our biggest and number one goal is really identify patients that have PAD or a risk of PAD and make sure that they get to the right place to we get them into the healthcare system.
Yeah, exactly. It makes so much sense because so many times we offer reactive solutions, right?
Hmm.
But in this case, focusing on that proactive, preventative solution of
Yeah.
saying, if we can get them screened, we won't have to probably worry about the additional cleaning and moving all the blood flow
Yeah.
around and everything. So let's get
Absolutely,
them early, right, in the
absolutely, and
system.
and 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 that's a good point. It's not always the patients need a procedure. Sometimes it's just
That's
a
right.
medication adjustment or starting a medication. It's not always a procedure. We do whatever it takes to
Exactly.
make sure that our screenings are busy and that people are excited about it. We bring music if we have to. We bring, we bring snacks. We make it fun. We try.
Yeah.
We want to make sure that there's good energy.
Yeah. And I love that you be creative with it because sometimes people get scared, right? We all know that maybe when, a lot of people, I think, don't actually get the care they should get because they're scared to go to doctors. They're afraid. There's a stigma there, maybe that they're afraid of what they'll find. So, any
Yeah.
way that you can make it creative and fun for people to get them involved in these screenings is incredible.
Hmm.
I mean, look at what October's done for women's breast cancer, right?
Yeah.
November for
Yeah.
men. All of these things are simple ways, but so important, right?
Absolutely, 100%.
Yeah, yeah, incredible. So as we wrap up today, I also spoke with your brother, Dr. Julio Martinez Clark, and I know the two of you also co-founded bioaccess. And I think it supports clinical research across borders, but I'd love to know the mission and goal with that as well, if you can touch on that.
No, absolutely. So, um, I've always been very interested in technology and in medical innovation and devices. And early in my career, as I got involved in that space, I noticed that it was very expensive in a very rigorous process to get a medical device approved in the United States. So it's really expensive and it takes a very long time. And you as a startup company have to figure out how to go to Europe to 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 get your clinical trials done and maybe get the approvals through the CE mark, which is a European approval. Well, I said to myself, look, I mean, we have really good medicine in Colombia, very good institutions, a very good healthcare system and network. We know a lot of people in Colombia. Why don't we figure out a way that we bring or we set up an infrastructure for clinical trials in Colombia and maybe later in Latin America to offer that as an option, cheaper option than Europe for those startup companies. And that's how it started. And the motivation was that because I used to do cases in Colombia, I used to, obviously I did a lot of my training in Colombia. The difference in technology when you did procedures and things like that, that access to care, access to technology, philosophically, I saw it as a way of increasing and improving access to state-of-the-art technology by bringing clinical trials and by bringing those early stage studies to a population in Colombia, South America. So that's how everything started, and now has become a pretty well established contract research organization that focuses specifically in medical devices, and now has kind of become a global thing. But our core strength is Latin America, many different countries in Latin America.
Oh, it's exciting. And I know I was talking back and forth with Julio, and we'll get him on the show as well to talk about bioaccess, because that's a whole nother side, which is really amazing.
Yeah, exactly.
All right. So to wrap up things today, at the end of every show, we have what we call the clear signal. And what Dr. Pedro shows us is that healthcare innovation isn't just about new technology, right? It's about access, it's about equity, and it's about compassion. But what I think really makes your work stand out is that you're changing the system itself, because through your practice, Amavita, and your foundation, Miami Initiative to Stop Amputations, MISA, very, very important we touched on, you're bringing world-class cardiovascular care out of the hospital and into the community where it's needed most, right? Reaching people who might otherwise be left behind. So again, your work reminds us that medicine is most powerful when it meets people where they are. So incredible job, Dr. Pedro Martinez-Clark. Thank you so much. Really interesting stuff.
No, thank you. It's been amazing.
I love it. So many good things to talk about. Again, please like and subscribe so we can continue bringing you conversations with top doctors like Dr. Pedro and healthcare leaders from around the world. And as always, follow us using @ or hashtag DocPod Health and the DocPod channel, because health, it's everything. Thank you, everyone.
Celebrating the world's best. This is DocPod's Doc Stars.